Thank you so much for joining us on our PCMH Learning Collaborative session number 15. Our usual teleconference reminders, if you could please mute the phone while you're not speaking and do not put your phone on hold so we don't hear the background music. Today's objectives are introductions, successful changes and strategies for improvement with our special guest speaker, Malaya Burrows from Prime Care Medical Clinic, medical complexity with Dr. Kuo, a PCMH update with Dr. Kuo, a message about our CQN ADHD project, and time for questions and open mic. Support has been provided by Arkansas Medicaid, and joining us today is our AAP leadership, Dr. Kuo, Dr. Orrin Davis, Dr. Chad Rogers, Dr. Chris Schluterman, and me, Kristen Pfeiffer, and our Executive Director, Amy Ollinghouse. And Malaya, I see that you're on the line. Would you like to start us off by talking for a minute about successful changes and strategies for improvement that you've been able to have going on in your own clinic?
Sure. Can you hear me okay?
Yes, I can hear you great.
Okay, perfect. I just got logged on, so I missed your opening announcement. So you just kind of want to know what's been helpful for us and key strategies, I guess, that we have found since we started PCMH last year. One of the huge things that we've had a lot of key components that we've kind of learned, like, oh, this is really helpful. One of the really big things for us is that our owner of our clinic is a doctor, Dr. Warnock, and he has been a pretty big driving force behind PCMH, which I know you don't find in a lot of clinics, but he's kind of one that initiated it, which is really nice because a lot of times I know people have trouble with provider buy-in, and a lot of times I've heard, the provider will say, well, I'm not doing a care plan. If you want to do it as the nurse, then you can. But as a provider, I don't have time for that. I'm not going to do it. And so that's been really helpful just to have the buy-in on that level and for him to have that vision on it as well. But then we also have put 2 lead providers in place that kind of do training with our providers. We have 4 different clinics, and we're an urgent care clinic, and we also do primary care, so it puts us in a little bit of a different situation than a lot of other clinics. We're open after hours, we're open on weekends, and so we're a little bit of a different scenario than a lot of other PCMHs are. But we put 2 of our physician assistants kind of in charge of the care plan program from a provider aspect. And so, I don't have any medical training. I have been in the healthcare industry for 7 years, but I don't have any, specific schooling as far as it goes with that. And so when it comes to care plans, even though I have been the PCMH lead for our clinic, it's been really helpful to utilize somebody that knows, what a chart should look like, and when somebody's talking about what should be in a care plan, they know exactly what that looks like. So that's been really helpful for us. We also implemented care coordinators this year, and I have one of them on. She is listening in. Her name is Alexia today. But we also implemented those, and we're still, working out the kinks of what that looks like and what's most beneficial for a care coordinator to do, but basically they're our patient advocate. And so a lot of times I think it's easy for patients to kind of fall through the cracks of things and, to kind of focus on, our shared savings, but are we really, focusing on this patient as a person, and what's the why behind what we're doing it. And it's not just, to qualify for shared savings, which is awesome, but, that's not our only thing that we're working towards. We want to also help these patients receive what I call a 360 degree of care. and we want to be your, we want to be your home. We want to know what's going on. And so our care coordinators research a lot of resources for us. So, we look at barriers and we say, okay, this patient has no-showed 5 times in a row. Why have they no-showed? Because there's always a reason why. I mean, they might just be non-compliant, but chances are they don't have transportation, and they thought their neighbor was going to take them to their appointment, but it turns out their neighbor fell and broke her hip, and so she couldn't come today, so she missed that appointment. And then the next week, their car finally got out of the shop, but then the tire blew out. And so there's always reasons as to why, and sometimes I think it's hard because we're like, oh, they're just non-compliant. But we've really found that there's a lot of reasons why, and if we can set them up for success in that, and if we can figure out the why behind why they're not compliant in our eyes and on paper, then we can really help them be more successful, and then it helps us in turn be successful, So getting them in touch with resources like transportation or food stamps. I don't take my medication because it makes me really sick. Well, why does it make you sick? You realize you're supposed to, always take your medication with food. Well, I understand, but we don't have the money for me to, I don't know, have the food that I need to eat with my medicine. And so I don't take my medication on a regular basis because my food isn't, always guaranteed. And so things like that where we can kind of help them and be an advocate for them. So something that has also been really helpful for us has been just identifying our patients in our EMR. Blue Cross is kind of adding Blue Cross in with Medicaid has kind of given us a whole different population of patients to work with, and it's just a little bit of a different ball game with Blue Cross versus Medicaid. And so we found a way to mark our patients in our EMR to be able to recognize when a patient comes in that they are a high priority beneficiary, and so we're checking, do they need a care plan? We're getting a really up-to-date visit on them when they come in, different things like that. We keep up with all of our patients in a spreadsheet. So we're saying, okay, it's now almost October. Where are we at on care plans? What is our percentages looking like? And we keep all those calculated, and then we go through, and our care coordinators go through and look and say, okay, I've got these 30 patients that haven't been scheduled yet for their second care plan this year. We need to get these patients in, and they kind of put them on a fast track to call and send letters if we can't get in touch with them, and do that. So we found a lot of things that have been super helpful. I don't know if you have any questions I could help answer, or I could probably talk about what we do and how we've been successful for a really long time. Our team has been awesome. I'm very passionate about them, and they have just really gelled together well, and we have a really good core group of probably 6 to 8 people that have been really beneficial in helping us be successful, and we are on track to get shared savings, woohoo, in October, so we're really excited about that. But yeah, I don't know if there's any questions I can help answer. If not, I might just ramble for like 30 minutes, and I know y'all don't want that. So.
Well, thank you so much, Malaya. Does anyone have any questions for Malaya?
Hey, it's Dennis Quo. Thank you so much, and that was a really awesome discussion and presentation. And I want to point out a couple of things that I heard from you just to kind of hammer some of the concepts home. The first is I heard there's an overall theme of leadership and teamwork, which we know is hugely important in driving changes throughout practices, and I think you mentioned some really good experiences and examples of that. Two is that I heard you talk about psychosocial drivers of health, or some would call another buzz term that's out there is social determinants of health. You talked about some of the reasons that you have found with care coordinators working as patient advocates with particular families about how some of the drivers for why there was not the adherence to visits or care plans that you wanted to see were coming from social drivers such as transportation, and how you're able to address those. The third thing I wanted to point out was I heard a very big theme of what I would call patient registries, and that since you've worked with your EMR, particularly as you added in the blues, the patients under the blues, that being able to generate alerts and tracking children as they were scheduled to be seen but may not have come in enables you to be able to really chase families down who are not having the access to health care that they really needed. And so I think those are just three important take-home messages that I just wanted to point out on what you just said. And I think that and I'm very excited to hear the work that you've done. I wanted to throw two questions your way, and then I want to open it up. The first is, can you tell us more about the qualifications of the care coordinators, you know, what training, degree, experience that you decided on? And the other is, did you come up with a appropriate ratio of care coordinators per patient, and what would that be, or what is your thoughts about what the appropriate number of care coordinator per patient is? A two-part question about care coordinators.
Okay, sure. The two care coordinators that we have in place currently don't have any specific, I guess, towards care coordinators, but schooling-wise, they don't have anything specific, you know, right towards that. But what we looked for is a lot of times when we're looking for people like this, we search internally, mostly all the time for any positions, you know, that we have clinic managers, things like that. We're searching internally before we ever go outside, because a lot of times you find people that really, you know, are passionate about what you're doing, and if you don't look inside first, then you might totally miss somebody that would be such a great fit for what you're doing. So, like I said, we have 4 locations. We have, our biggest clinic is in Searcy, and then we have 2 clinics in Conway, and we have a clinic in North Little Rock. And currently we just have 2 care coordinators. One of them is kind of over the Searcy clinic, and the other is over our Conway clinic, and then our North Little Rock clinic is a new clinic, and we've had it for about a year, and so it's still growing, and so that one is kind of shared, if you will, between the 2 of them. Okay. And so our care coordinator, Jennifer in Searcy, she actually went to school for, I believe it was social work, and she's very passionate about that. And so one of the things that stood out to us about her was before we even were looking for somebody for this spot, she just loved, I guess, helping people. We had this elderly couple that would come into our clinic weekly, and it became something to where, you know, we realized they were coming in not because they necessarily needed to be seen, but because they needed that attention of, you know, just like family. They didn't have anybody, and she really took to them and got to know them on a deeper level and found out that the apartment that they were living in was roach infested and just a really awful place to live. They were losing so much weight because they couldn't afford food because they weren't set up to be able to get food regularly, and they both had a lot of disabilities. And so when she found all this out, she made it her personal mission to get them qualified into an assisted living home. And so she got them all in there as like her, you know, huge proud moment, got them all set up in there, and they started gaining weight, and they don't come to the clinic as often. You know, they're only coming when they're sick. And so I think that kind of depicts her heart, you know, for patients, and really was a key reason why we picked her, because that's really what you want, I think, in a patient care advocate. You know, we always say you can't teach character, but you can teach skills. We can teach. We're still learning about PCMH. We're still kind of learning as we go. But you can teach skills, and we can learn things and say, hey, you know, you need to learn how to do this, but you can't teach that care for patients that she already had hardwired into her. So that was a big reason why we picked her. Our Conway one is Alexia. She's on the line today. And Alexia, I can let you talk about kind of your background on schooling since you're on here if you want to.
Hi, Alexia. It looks like you're on mute.
Hello?
Oh, there you go. Hi, Alexia.
Hi. Yes,
Welcome.
Hi, Hi, nice to meet you, and thanks for so you're on the call, Malia. A little bit of my background is that I have a bachelor's in health education, and right now I'm currently working on my master's in education.
Okay, that's great. And can you talk about how your education, do you mind if I ask you the question of, I'm interested in how your education prepared you, or what kind of resources do you think that your particular background may have contributed to your duties as a care coordinator? And I think this is a fairly hot topic about the, not just what would qualify somebody to be a care coordinator, but what kind of experiences and training do different backgrounds bring to the position of coordinator. And so just kind of thoughts about that, including things that frameworks, theories, et cetera, that you learned in your training and experience. I think I would like to hear that.
Okay, so this is my first experience working as a care coordinator. I actually previously I didn't have any experience in it. The main reason why I was interested in this position is because I truly do care very much about patients, and just from my education, paying attention to social factors and different medical issues that patients face, I believe it made me more, as a care coordinator, makes me more, I can see things in patients to help them get the best health care and have successful changes in their health care.
That's great. I actually wanted to ask you, or also, Malia, the other question I had was to just kind of indicate some successes about, but actually, now to think of it, you've already talked about the family that you just, that was just presented, the one with the moving to assisted living and because of the roach-infested apartment. And I think that hearing stories about that is really important to help us, kind of keep perspective of how much we're helping our patients and families. But thank you. And I'd like to open up to questions from the general audience, just about experiences to share or questions for the Prime Care Medical Group.
Hi, this is Amy. I have a question. And it may be too sensitive, but the salary ranges for care coordinators, what do you think is an acceptable salary range?
We don't necessarily have a specific salary range. The two ladies that are in these two positions have been with us for around 3 to 5 years each. And so it's something that there's not necessarily, like I said, we haven't hired in from the outside, and so it hasn't been something that we have said, okay, this is the salary for this, and this is what we're going to do. And again, it's something that we're still learning and we're evaluating, so we might say, hey, this is what we're paying you now, but, after evaluation and seeing how intricate of a part you have in PCMH, we actually want to change that. That's something that we're still working on, but these two ladies have transitioned. Jennifer transitioned out of a billing position, actually, and Alexia transitioned out of a receptionist position. And so it's not something that was like we brought them in from the outside, and so it was a whole, a research in that. So I don't know that that's super helpful.
This is Dennis Quo, and the part I chime in is that I think that every practice is going to be different in how the care team is put together and what the needs and resources are needed from care coordinators. And so when we're talking about staffing decisions and qualifications, what I wanted to do is illustrate just sort of the broad range of how high-functioning teams are able to utilize their staff and their roles, and how there can be variation in how specific pieces are put together. As far as, what we typically, a lot of places use folks with either a nursing or a social work background as care coordinators. I've seen models for folks that have used, parents specifically, either volunteer or paid navigators, health educators. Regarding nursing, I've seen models anywhere between, I've seen RNs as care coordinators, I've seen LPN as care coordinators, and I think that, any sort of, salary range really depends on the work experience and the duties of what you would expect that particular care coordinator to do, particularly since the skill set is going to be different. The skill set that's necessary is different depending on who's on the team. So I'm really glad to hear the prime care experience of someone with a social work background and someone with a health education background, and I think that those are really just great examples to hear. Other questions or reactions or thoughts or any parting words of wisdom from your group?
I did forget to mention one other thing that we're looking into that I think is pretty neat and I wanted to share. We're looking into incorporating ancillary services. So one of the ones we've really looked strongly at is counseling, because we found most of our patients that were on our Medicaid high priority list were on there because of mental health problems. And a lot of things can kind of trigger back to that. And so you might have anxiety attacks because you know, XYZ needs counseling, whatever it is. But those patients a lot of times fall in the ER because they have a panic attack in the middle of the night. They think they're having a heart attack, and so they take themselves to the ER, and that drives up your cost. And so getting back to the root cause, kind of what I talked about of why are you high priority? Why are you on our list? What can we do to help you with that? And so mental health is a huge one, and so counseling is something we're trying to incorporate in-house, so we're not sending out as much. We have ultrasound, that's a new thing. We have it just in Conway. We might broaden it a little bit more. We also are looking into derm and casting. So just some different services that make us a little bit more well-rounded, and we're not sending out as much for, and we can keep more in-house.
Okay, great, thank you. Other questions or anything else? And any other parting thoughts from folks? Okay, well, with that, I'm happy to move on. Malia and Alexia and the Prime Care group, thank you so much. That was just really awesome to hear your experiences, and we really appreciate your time for talking with the group today. Okay. Kristen, go ahead and go for the next slide, please. Okay. I'm going to take a little bit of time to talk about medical complexity. This is a topic that we've heard a little bit before in past learning sessions, but most of you know that I also work in a medical home clinic at Arkansas Children's Hospital, which is a complex care service. And Dr. Pat Casey and Dr. Rob Lyle had relayed to me that there were some questions about the nature of medical home clinic and the role for complex care that was coming from a number of folks who were in care coordinator positions around the state. And the way they framed it was folks who were working under the PCMH model. So I actually invited them to try to make it on the call today, and neither of them actually were able to clear their schedules for this particular phone call. So they asked me to go ahead and talk. So I'm going to put my ACH Medical Home Clinic hat on behalf of the Medical Home Clinic and just talk a little bit about complexity and the role of complex care within a healthcare system. Kristen, next slide, please. So we want to define children with medical complexity as the children who have multiple chronic conditions. They frequently have a very high prevalence of neurodevelopmental disability. A lot of children with cerebral palsy, they may have had prematurity. You know, when you have neurodevelopmental disability, there's generally a cascading effect of other health systems. Respiratory, GI tend to be affected, for example, certainly musculoskeletal. And many children have technology needs, such as a gastrostomy tube. They may have a tracheostomy. They could have a VP shunt. And so that adds up to just a lot of needs and frequently a lot of dollars. Next slide, Kristen. The next slide is a diagram that a number of us put together and published several years ago. I want folks to recognize that when you're looking at medical complexity and you're talking about the need for a multidisciplinary team and collaborative care, you really should have a combination of service needs in the upper left-hand corner, chronic conditions in the upper right-hand corner, high resource use, healthcare use in the lower right-hand corner, and functional limitations in the lower left-hand corner. And this is a very, very specific group of kids. These kids are the ones that, if you hit all the domains, are the ones that are, you really need a more intricate healthcare system to be able to manage their healthcare needs as well as possible. And simply hitting one or two of these domains, garners a different response. So, for example, if you've got high resource utilization, but you don't have the chronic conditions, what you likely need is psychosocial intervention or social work. And, if you have substantial family identified service needs, but not the chronic condition, that can be the same response, necessary response. Next slide, Kristen, please. Children with medical complexity, there's a lot of attention being paid to them because, they're really a target for healthcare reform. So when we talk about PCMH, it's important to recognize that PCMH is necessary but not sufficient. You're talking about less than 1% of the kids comprise about a third of healthcare costs, the vast majority of which are inpatient costs, and that depends on the study you see, but it's at least half, and it could be as much as 3/4 of costs are actually in the inpatient area. Staggering impact on family. And one thing that we're finding is that a lot of these families are not reporting a whole lot of active management from the primary care setting. So in a survey that a number of us did across 3 institutions, we found that fewer than 2/5 of families said that they were really getting a lot of chronic illness management from the primary care physician. And when we're talking about a healthcare model that is really focusing on the patient-centered medical home, I think it is worth kind of thinking about the challenges of taking care of such children from the primary care setting. Certainly there's financial and logistical challenges. And in some cases, these are the kids that Arkansas Medicaid, when they ask us to designate several children for exclusion, sometimes these are the kids that may be excluded, but they're still there, and we need to be able to take care of them. Next slide. Those of you who have seen me talk before know that I like this model, and I wanted to point out that if you look at the inset of the upper right-hand corner where it says that a healthcare organization says that you need to have a medical home that's taking care of children with chronic care needs, that you need to have care partnership support, which is that families need to be supported as partners in a healthcare system. Delivery system design means you talk about things like workflows and information flows and things to be able to access and things to be able to help your healthcare system move smoothly. Decision support is the need to be able to support providers at every level so that the correct medical decision is made at the point of care. And this is when we get into things like collaborative care and co-management, to be able to work with at different settings, whether it's the primary care setting, the emergency room setting, inpatient setting, so that the child gets consistent care as much as possible. And clinical information systems is the use of electronic medical records and registry tools to be able to prospectively identify such children and to generate alerts and to generate reports so that we know how we're doing. Next slide, Kristen. So the role of a tertiary care center-based complex care service, a number of these services have risen over the last 10 to 15 years, and a medical home clinic is one such service. They're typically based in children's hospital, and they focus on children with medical complexity. Most, like the medical home clinic at ACH, have a consultant model of care. So that means that while the clinic does provide care coordination from the tertiary care setting, it also offers expertise in managing health care conditions. This clinic tends to focus very heavily on nutrition and growth and a whole person orientation addressing respiratory, GI, neurodevelopmental issues. Next slide, Kristen. It's important, though, to remember that the medical home clinic is not a primary care service, and we expect that children continue to get primary care from the primary care site, the PCMH site. And when you talk about the most effective way to care for children with medical complexity, it's really a collaboration. There are specific roles for primary care, specific roles for the specialty care setting, and specific roles for families. For the child with complex care needs, the thinking behind a complex care service is that there are specific interdisciplinary services such as nutrition, speech therapy, care coordination services within children's that we would offer, but the primary care physician would continue preventive care, routine acute illness care, and providing frontline assessments for acute problems. We talk about helping families with worries and concerns and addressing school developmental issues. Medical home clinic at Children's can certainly address some of that, but I think that there is a huge role to be able to maintain that in the primary care setting if a practice chooses to refer a child to medical home clinic. Next slide. So the medical home clinic started in 2006, and we work 6 half-days a week. We have 3.5 FTE nurse clinical time. Right now we take care of about 670 patients. We have speech, nutrition, social work, and psychology present in the clinics at all times. Next slide. And as I said earlier, a collaborative co-management does not replace primary care. And I think that it's good to really think about how this collaboration can really work well. Some of you in the call, I know I have personally discussed some patients with, and I would suggest things like coordinating appointments so that we're not duplicating what each other are doing. For many of our kids, we can supply some of that coordinated nutrition, respiratory, GI assessments, and also discuss the care with folks at ACH. But we expect that we can definitely work out dividing the visits between different sites so that the family is not overburdened with multiple visits. And I've also worked with a number of folks, some of whom may be on this call, and say that we also will sometimes see kids for very specific purposes, but the primary care setting maintains primary management of the entire care. We do provide individual health summaries. We typically will see kids every 3 to 6 months. We work only in physician referral, so that's something to consider. And I feel fairly strongly that if somebody who is not the primary care physician refers a child to medical home clinic, that I think that the child, that we need to make sure before doing any intake that the primary care physician is supportive of having a tertiary care center manage complex care needs. So this is really for a fairly small number of kids who would really need to be referred to a tertiary care setting for complex care. But I wanted to review that for folks, particularly for folks who may not have been aware about where medical home clinic sees its role. that complex care services around the country are developing the same care models, and you know, we see this as a partnership for the children to try to meet the level of needs for kids who really need that level of care. Kristen, I think that's the last slide for this. Can we just double check that? Yeah. Folks, tell me, particularly on behalf of Medical Home Clinic, what questions you have or comments or thoughts about how this fits in with the PCMH concept. Okay. I want to give a little bit of a PCMH update along with some, you know, kind of some news about future opportunities and developments down the line. Kristen, next slide. So just a reminder about 24-month metrics are coming up, documenting EHR for care coordination. There's another reassessment for practice, transformation and care coordination activities. You all have seen your 18-month quality improvement plans. If there was anything that you had to fill out a QIP for, we hadn't heard anything regarding 18-month QIPs. The care plan audit is happening. We know of a number of folks who have gone through early audit for the care plans and have passed. I know of one that has not passed, and I haven't heard any more details on that, but I have heard a number of practices who have passed the repeat care plan audit and when they chose to go early. You know, the official word is to continue working with your practice transformation facilitators to make sure that you're you know, prepared to prepare your audit successfully. I'm wondering if anyone has any thoughts, questions, or concerns about the upcoming care plan audit that we can either answer, discuss, or take back to our partners at Arkansas Medicaid and AFMC. Like, has anyone gone for early audit, for example, and you know, is happy to share any experiences? Okay, we will ask for more thoughts or suggestions as time goes on. We have heard repeatedly that the intent is for folks to be able to have their assessments properly done so that we can get our successes recognized and passed. So that is something that we've heard repeatedly, is to make sure that it is made, you know, to be as easy of a process as possible. And as I said, please give us feedback or suggestions if you have any thoughts or reactions to how the care plan audit is going. Next slide. We covered some of these updates on the last call, so I'm just going to breeze through them. The practice support metrics are going to, the plan is to make them go away, and that care plans for high priority beneficiaries are going to become an activity that we attest to. All the others, the number of HPV 2 visits per year, hospital follow-up, and non-emergent emergency room will become quality metrics or be given to us solely for information purposes. They are introducing a number of other new quality metrics, however, that we would use to judge shared saving opportunities. And one is upper respiratory infection, and then the others are adult focused, so I wouldn't concentrate on those if we're in pediatrics. Next slide. Okay. One other, okay, let me go through this announcement. So open enrollment is currently going on right now. The deadline to re-enroll is November 13th. The Q3 PCMH report is coming out September 22nd, and the latest word for shared savings payouts are coming in October. So just be on the lookout for that. Next slide. We have talked about future topics in the Learning Collaborative, and I actually have one other that besides the ones that are listed here. We've talked about talking about care teams, family advisors, quality improvement huddles, workflow analysis. I learned one interesting thing this morning that I think is we're going to discuss on the next Learning Collaborative call. So after these slides were produced, I was on a phone call this morning with Arkansas Blue Cross Blue Shield has periodic conversations with a number of primary care providers. And what I learned this morning is that Arkansas Blue Cross Blue Shield, starting in 2016, is going to adjust their upfront PMPMs for under PCMH. They're going to adjust them based on whether you have NCQA certification or not. So that is, they're using that as an opportunity to incentivize practices pursuing NCQA certification. My general question for those is, we have not really talked about NCQA certification for medical homes, level 1, level 2, level 3. I know of one pediatric practice in the state that is NCQA certified. There's about 100 practices in the state that have NCQA certification, a little over 100, medicine practices and family medicine practices. But one med-peds practice is NCQA certified. I know I can't have a show of hands because we're doing this virtually, but I'm interested in gauging responses on whether folks have looked at NCQA certification, or let me ask this question, do folks know what NCQA is? Have folks heard about NCQA? Do folks know what NCQA is?
Yes.
Have folks looked into NCQA certification in the past?
Dr. Kuo, this is Lori from Mercy, and we actually did have certification that we let expire last year because it's a ton of work and
yes,
we weren't getting rewarded for it. So now that they're going to pay additional for NCQA certification, we may look at it again.
Okay. Thank you. I'm going to come back to you on that because I'm looking for folks who have experience with the certification and where that's going. But what I spoke with Alicia Berkmeyer at Arkansas Blue Cross Blue Shield today as well, separately, and I think that based on what she told me and based on what I'm hearing from around the country, is that more and more of the payers will be incentivizing with NCQA going forward. I'm aware that this is the first I've heard of any payer in Arkansas paying extra for NCQA certification. And I'm not at a position where we can talk about what the dollar amounts look like, but I know that's starting to happen. And so we have thought about, we're thinking that we should have some discussion on this group about NCQA, and I'd love to be able to touch base with you about kind of your experiences, because I think sharing the experience of NCQA certification is going to be helpful for all of us. Other thoughts about NCQA? Folks looked into it. Folks have had certification in the past. Folks looked at it and was wondering whether it's worth the time.
Dennis, this is Tony.
Hey, Tony.
We've started looking into it and have actually purchased the new product that the AAP has that you can do it all online and so it's not too expensive. It was like $300 or $400 for the whole group.
Okay.
But it's a way so that rather than having piles of paper, it actually guides you through the process, and they've got the new updated NCQA guidelines. And so we've started that process, and we're in the process of trying to kind of, with a goal over the next 6 to 12 months to try to get it done. So. Great.
Okay. I would like to ask a follow-up. Tony, I'd like to follow up with you about that, because one thing that I think that we want to be able to pull together is what the available tools are for folks. I'm aware that there's a number of folks in the state who specifically worked with practices on certification. I'm aware about the tools, some of the tools, but I think that putting that out there and hearing about experiences is going to be helpful for folks going forward. And as I said, this is I had a feeling this was coming, but this is the first concrete example of what I heard, that NCQA will be likely incentivized from a payment perspective going forward. Any other thoughts or reactions about it? Okay, next slide, Kristen. As always, we're watching the Healthcare Legislative Task Force. Our group we've been in discussions with the Stephen Group about what's coming down the line. The final report from the Stephen Group, who is the consulting group, is due on October 1st. They were actually very, very complimentary about episodes of care and patient-centered medical home as a design, from a design standpoint, and note that there were a number of very excellent early successes from both programs. Having said that, their report is advisory in nature, and we will digest the report when it comes out, because we're going to have to get a reading on how the report will then play into discussions that will be happening on the legislative level, because that will also help us give us an understanding of how PCMH, in its current form or within modified form, would continue, in the future. But as I said, they were very complimentary of the program and what Arkansas has done. So, I think in that sense that we're very hopeful that all this will continue, but we will have digest and have more discussions about it after the report comes out.
And Dennis, I would also add that the governor's appointed task force, which I'm on, is meeting tomorrow, so we should hear a little bit more information on what's going on and get up to date.
So I think that, thanks, Amy, and I think that to add on that, I think all of us, and particularly the Stephen Group, has emphasized that the payment changes that we're seeing, paying for performance, paying for value, the need to move towards registries and population management, moving away from fee-for-service, all of that is coming to Arkansas. Some of it's already here, but it's going to continue to accelerate. We need to be able to demonstrate doing data queries. We need to be able to demonstrate, our own outcomes. To emphasize something that they've mentioned repeatedly, a lot of this is not set in stone. We know the directions are coming. We know the federal CMS is really pushing this direction. How exactly this all looks like is actually still relatively flexible. And the chapter is committed towards making sure that children's health is well represented as things like metrics and payment designs get rolled out. I have heard, for example, kind of thoughts about when is the right time to put in immunizations as one of the metrics. Kind of give you another example of what might be coming down the line. Nothing definite on that yet. Next slide. Okay. And the last thing I think this is the last, really the last major slide, is that, Last week, Kristen and I and Dr. Peter Jensen, who is the acting chair of child and adolescent psychiatry at UAMS, the chapter has been awarded the chance to participate in another learning collaboratives, very, very similar to the one that we did for ADHD 2 years ago and 3 years ago, but this for asthma. But this one is focused on ADHD. And we are going to launch this at the end of this calendar year, going through next year. We have some more details. The written materials are coming soon. But if you're interested in participating in improving ADHD, we think this is really going to be a fantastic project. There were 6 chapters around the country that are participating with us. To give you a flavor of what this is all about, we're going to have the same monthly calls, and we're looking to roll in this monthly call with the ADHD calls, so we're not doing too many calls at once. But the intervention is to utilize an electronic portal software for ADHD management called MeHealth. This was developed by a guy named Jeff Epstein at Cincinnati Children's, and it's a way to do Vanderbilt assessments and track Vanderbilt scores and be able to do assessments between the parents and the teachers online, and to be able to get them quickly and to be able to track progress quickly and to be able to keep kids in the registry quickly and be able to measure these outcomes. And it's really a fantastic program. It's going to, we really think, it's been tested quite a bit at Cincinnati and other places, and it's a really exciting piece of software. Everybody came away from that meeting saying, wow, this is an amazing opportunity for us to really improve how we get our ADHD data and information and do our assessments. Dr. Peter Jensen, we just have an incredible opportunity to work with him. He is the founder and director of the REACH Institute, which is a nonprofit organization that has worked specifically to train and support primary care physicians in managing mental health conditions. And so this is just an incredible fit for all of us to have him come on the team. So, as always, we will offer MOC Part 4 credit for pediatricians who participate. And I know a number of folks on this call have expressed interest in participating, and I can't tell you how excited we are about this opportunity. So we are supposed to get all of the enrollment material sometime in the next week or two, and then we'll start spreading it out. Questions about the ADHD project, about what this is about, what the intervention looks like, what the responsibilities are? Okay, so Kristen will follow up with practices, and it's 1:08. And other questions, concerns, things that have come up that you're seeing that we want to discuss? Okay, I think with that we'll close, and thank you for an excellent call. I really appreciate the participation and the discussion, and we will be in touch, so have a great day, everybody.